Today, we are on site in Washington, D.C. at the Association of Community Cancer Centers annual meeting and Cancer Center Business Summit. We will be recapping some of the top news presented each day during the meeting, and soon we'll speak with Tom Gallo, the outgoing president of ACCC, on trends in oncology care and preparing for the future, and Nicole Braccio of the National Patient Advocate Foundation on shared decision-making and other conversations with patients. Welcome to AJMC On Location. I'm Jamie Rosenberg. The meeting kicked off with a look into the future with sessions that analyzed how physicians, nurses, and administrators will adapt over the next 10 years as cancer practices grapple with business, quality, and technology trends. There was also a session on federal policy shifts that impact care delivery, reimbursement, and patient access to care, as well as the government's role in changing the healthcare landscape. Read about these stories and watch additional interviews from the meeting at ajmc.com. Here now to discuss some highlights from day one of the meeting is Tom Gallo. Thank you so much for sitting down with us. We're excited to have you here.
Thank you.
So to start off, day one of the meeting, spent some time this morning looking towards the future. What are some big changes currently going on in cancer care delivery that make looking toward the future crucial?
Well, I think that there are many changes going on, as the two speakers this morning highlighted. First of all, the developments in genetic testing have certainly impacted cancer care. The new technologies that have come out, including proton therapy, as well as many of the targeted chemotherapies and immunotherapies that are out there. And the cost of those therapies have certainly had an impact on cancer care and the cancer care delivery system, and we're having to adjust to those changes today.
Great. And so what are some trends influencing oncology services that you're particularly excited about?
Well, again, I think what we're seeing is we're seeing our patients survive a lot longer than they have in the past. And I do think that the cancer care system is becoming more patient-focused and patient-centric. And we're being able to, through some of the innovative programs that are out there, including the oncology care model, we're able to provide additional services to patients that we weren't able to provide before, such as some nutritional services and social work and financial counseling services.
And so what are some of the biggest shifts in oncology, whether they be policy, economic, technological, that are affecting the care team?
Again, I think targeted therapies and immunotherapies have been a game changer in oncology. I think the utilization of AI, artificial intelligence, in terms of pathways and determining how we treat patients is also coming to the fore currently as well. I think these are all exciting changes, and I think, again, these are just kind of the beginnings, and we're going to continue to see rapid advances in these areas.
And how are these shifts impacting how care is being delivered?
Well, I think they're making care more complex, and so that there are additional educational demands on the cancer care team. ACCC is certainly trying to address that with some of the programming that we have here, try to educate the cancer care team in terms of the new technologies and both the positives and negatives of delivering those technologies.
Great. And how has the structure of the care team changed in response to different outside forces?
Well, I think the cancer care team has expanded as a result of some of the changes, and I do think so. Again, I think we've added some additional ancillary services because it's not just the technical medical care that is important to the patients, but also some social and psychological services, nutritional services, which are also important to them. I do think what has happened is the cancer care team has become more integrated. There's more communication between the various caregivers and providers, and I think that has resulted and will continue to result in improved levels of care.
And what burden is being placed upon the care team with the quickly evolving cancer space?
Yeah. It's difficult. I think that the burden on providers and the cancer care team is growing as the number of patients and the complexity of care increases, definitely. At the same time, we're seeing shortages of physicians and nurses and other caregivers in the field, so we've got to work more efficiently. This has certainly resulted in some burnout And so one of the things that we're trying to focus on in ACCC is building resiliency in our teams so we can care for the caregivers, so to speak.
Well, thank you so much for sitting down with us today. I really appreciate it.
Great, thank you.
Next up, we have Nicole Braccio, who is the Policy Director at the National Patient Advocate Foundation. Welcome, Nicole. Thank you so much for being here with us today.
Absolutely, my pleasure.
So first off, you have a session on early integration of pathology into the cancer service line. How is pathology currently utilized in the cancer service line, and ideally, how would it be utilized?
Yes. Well, I'm super excited to be here today on the panel and have learned a ton from my colleagues who are pathology and genetic counselor specialists. So it's interesting because I'm a pharmacist by training, and so I have face-to-face interaction with the patients almost on a day-to-day basis. So for our pathology colleagues, I understand they don't always have this opportunity, and I think the ideal situation would be the pathology team, whether it's the pathologist or the genetic counselor, could engage with the patient early on at the point of diagnosis or once those test results are produced. I think there is no pathologist counter, whereas everyone kind of knows their pharmacist, but not everyone knows their pathologist. So I think kind of socializing them a little bit and being able to have that conversation face to face, because pathologists and genetic counselors are well positioned to really explain the test results to patients as well as answer their questions, whereas I think now that responsibility lies largely on the oncologist, where the test results are communicated through a paper summary, which is often difficult for patients to understand. So I think collaborative efforts where the pathology team is engaged face-to-face with the patient would be the ideal situation for them.
Right. And a lot of conversations surrounding cancer care emphasize the importance of patient-centered care. How important is shared decision-making between patients and their providers to ensure that this patient-centered care is happening, that the patient's goals are heard, and that they're actively involved in their treatment decisions?
Absolutely. If I may, I'd like to make one small distinction, but impactful. So the term patient-centered care, I think, has kind of become a buzzword nowadays, and patient-centered care often focuses on disease management, whereas the term that we at NPAF like to use as person-centered care really encompasses the whole person, including the family, the caregiver as part of that unit of care, and focuses on what matters to the patient in the context of how they see it. So I think it's more so about putting yourself in the patient's shoes to be able to address all of the factors that may be top of mind for them, so financial, socioeconomic factors and needs, as opposed to kind of just focusing on the disease. But to answer your question, shared decision making is absolutely paramount to making sure that people are fully engaged and are involved in the treatment decision. At its core, it's really about a true partnership between the patient and their provider or their clinician. So Patient Advocate Foundation actually conducted focus groups with people to better understand, how they kind of see this relationship. And what stood out for me is that patients really wanted a true relationship with their provider rooted in dignity and respect. And I think those aspects are the foundational structure for shared decision making, and really co-creating a care plan between the patient and the critical expertise that they bring to the table about what matters to them, as well as, of course, the clinical expertise of the provider in bringing the treatment options, but then being able to sit down and have a real honest conversation about that. And ultimately, people feel heard, they feel like they're more engaged. And I think that's starting to happen more, but people are often a little maybe more timid or not always as engaged as we might imagine.
Right. And so shared decision making can be improved. What are different ways or efforts that can be put forward for this to be improved?
Absolutely. Well, there's 3 to 4 things I'd say. So one is better preparation for patients and caregivers and the families as they walk into these conversations with their providers. So for every appointment, really providing the tools, the education, helping people figuring out what questions to ask, or even other aspects of their care that they might want to raise to the providers that they wouldn't necessarily think to raise. I think people are often told to present their case as if they were a member of the care team, but they have obviously a different role and unique perspective to bring about their own family life and values that is equally as important to the conversation. So preparation for patients and caregivers is one. The second is training and education for clinicians to be able to have these conversations. I don't think there's a standard procedure or way that these conversations typically take place. So, and that's fine, because it really depends on how comfortable the patient feels to have these conversations, and it's up to them how engaged they want to be. I think we also did a survey to understand where patients feel and how willing they are to divulge deep information about themselves, and most of the patients that we interviewed said that they wanted to be involved in these discussions and shared decision making, and a very, very small percentage, I think only 2% of the people we surveyed wanted the doctor to make their decision completely. So I think there's a balance of trust and how engaged people are. And I think the third thing that would help foster shared decision making is allowing enough time during these appointments, right? I mean, how often have you been to a doctor's office and you're rushed out, or you have 15 minutes and then you feel like, oh gosh, I wish I asked those questions after. So it's allowing for enough time, and maybe that's not every appointment, but during key decision points during the treatment course, as well as maximizing the rest of the care team to help with these conversations, so it doesn't only rely on the oncologist or the clinician.
Great. And as a patient advocate, how are you in a position to help patients with the financial toxicity associated with their treatment, and also help them make decisions about their treatment with the cost of care in mind?
Absolutely. Well, there's kind of two sides to this. So my colleagues at Patient Advocate Foundation provide direct case management assistance. So they do navigation, financial assistance, as well as provide education to help with these conversations. But oftentimes the people are contacting PAF through a call line, and it's often when it's too late for those early conversations to happen. So it's after the fact, when they've already accrued a great amount of medical debt and are trying to get that resolved, or they've came up to the office and realized, oh, the treatment that I decided on with my physician is not covered by my insurance, and so they're trying to work those things out. But PAF also provides educational webinars and has really great resources on their website, patientadvocate.org, that helps people also a little ahead of time to, one, choose a healthcare plan that will be comprehensive enough and meet all of their needs, especially if they know that they have a serious illness. I know for cancer, obviously, that's not always the case, and this diagnosis can come up with no advance notice, so that can be really tricky. But at the same time, they also have resources to help with how to file appeals, how to work through the system using the people who are already in place to help. And then PAF will also help link them to financial resources such as stipends for things like transportation assistance, even copay assistance, and helping them to apply for other financial aid they may be eligible for. I think the other piece is both NPAF, where I work, and our sister organization PAF are taking proactive steps to really educate people about these financial implications of serious illness. And so we have a webinar series called Cost of Care Conversations that will be posted on our npaf.org website that talk about and help people feel comfortable bringing up money and cost, because they are two different discussions, but we're trying to encourage folks to, if you're comfortable, be comfortable speaking about these kind of maybe taboo subjects with their clinicians and feeling comfortable opening up. And then I think the other piece is just making sure that people have awareness about their health plans overall. And so we've done some webinar series around that.
Great. And so racial, ethnic, and other disparities continue to persist when it comes to access to care and in turn these patient outcomes. So how does your organization work to improve equitable access to care for all patients?
Yes. So I think there are also two main approaches for this as well. So one, the NPAF team, we work with our grassroots volunteers on federal, state, and local levels, but really raising awareness at the federal and state level about these health disparities, and also the safety net programs that can help close the gap for some of these needs that pop up. So for example, Medicaid is a huge safety net program in this country that many of our patients may rely on, as well as others who are lower income, more vulnerable, and rely on Medicaid for the health services they provide. Another is nutritional programs like SNAP. So preserving these crucial safety net programs, because oftentimes health disparities exist because people are not able to get access to a doctor's office or help with nutritional support that can eventually produce better health outcomes when taken as a whole. And I think the other piece here is, of course, Patient Advocate Foundation does serve as a safety net program, a private safety net program, but certainly does subsidize a lot of the gaps here that people are facing. And then on the other end, we have our my PAF colleague, Shanta Chambers, who is our health equity lead. So she's actually going into local communities and meeting people where they are. And I think that can't be overstated as an approach to address the health disparities in the areas that we're reaching, because without knowing who the community leaders are and what resources are available in these pockets around the country, it's hard to kind of link people to the resources. So Shanta Chambers will go into these communities, learn about the unique needs of their population, and then help connect them with others in the area, as well as to our PAF resources. So we're hoping to kind of tackle this issue on both ends, but of course do work with other partners, other patient advocacy groups who are also focused on a lot of the same thing.
Great. And sticking with access to care, are there any policies that are restricting access for cancer patients that you could think of?
Well, I think the political and the health policy landscape in the past couple of years has been quite volatile, and I think in 2017, when there were debates over repealing and replacing the ACA, the Affordable Care Act, I think that was a huge challenge for especially cancer patients, because of course if you're a cancer patient, you have in and of itself a pre-existing condition. I think there were a lot of concerns about whether or not the pre-existing condition protections that the affordable health care plans would cover, and whether or not they would be able to deny people insurance outright or charge them more because of their health condition and cancer. So there were a lot of sort of threats and challenges facing policies that were put in place to help protect this access. But I think now we're seeing a lot of reimbursement challenges as well, because many of these new cancer drugs are, incredible in, almost curing patients, but really improving their quality of lives as well. When they do come with the high price tag, it is obviously very difficult for people to secure access to them. And so I think there's one piece of legislation, the CREATES Act, which looks to kind of improve and increase availability of therapeutic alternatives to some of these higher cost treatments, like biosimilars and other generic drugs. So there's that piece of it, but I think there's plenty of other activity in the states that also can help increase access to care. So, and I think my final example here will be step therapy is another kind of interesting space, because step therapy is a tool that health insurers use to essentially manage costs, right, across our population. So if a cancer drug that's taken orally is administered through the pharmacy benefit, insurers can, require a patient to try and fail on a lower cost therapy before this prescribed drug can be given. And so luckily, it seems as though that this is not done as often for cancer patients for obvious reasons, but it still can pose a threat to access. And so NPAF has been really active in a number of states, including Virginia and North Carolina, and we're happy to say that Virginia actually is the latest state to pass step therapy reform, so that people who are taking expensive therapies for cancer or for other diseases are able to get that treatment without having to jump through hoops.
Right, now on the other side of things, I know you mentioned part of the CREATES Act trying to expand access to alternatives. Are there other policies, or maybe not legislation, but efforts being put forward to try and expand access?
Right. I think a lot of this has to do with the ability for the health systems or the offices to receive reimbursement and billing support to be able to navigate the insurance benefit design. So I know patient navigators were at some of these institutions are a huge help. Case management, similar to PAF, but within offices, who can really help make sure that if a patient needs a prior authorization for cancer treatment, that can be done as expeditiously as possible. And even in my own pharmacy practice, I know it's different because it's a community pharmacy, not in an institution, but we have even billing specialists who only handle prior authorizations and handle access to care issues. So I think it's a myriad of ways that the health system is sort of kind of evolving to address this. But I think, people being aware that they have the power to advocate for themselves, and oftentimes this involves a caregiver or family members to really act on their behalf. But to know that there are resources out there, and it's just a matter of finding them. And I think the outreach efforts that we've done at PAF have helped to bring this to light. But I think, of course, a lot more work needs to be done to make sure that everyone has the benefit of these powerful resources.
So now, looking at palliative care and hospice care, they're both typically underutilized in different cancers, specifically blood cancers. What are different efforts that are needed to make sure patients and their families know about these services, don't have misconceptions about them, and then in turn, access is improved for them?
Absolutely. I'm really glad you asked that question, because I think still now palliative care is misunderstood, even though I know the subspecialty has been around for quite some time. So in short, there's really two things. It's professional and public awareness of palliative care and these resources. So I know CAPC, the Center to Advance Palliative Care, they provide resources and training and tools for clinicians who are treating patients with serious illness. Now, I know if you ask any person on the street, they may think that palliative care is end of life or that you're giving up, but quite the contrary, palliative care can be given alongside disease-directed treatment, and it's about improving quality of living as much as it is, helpful during the end stages of life. But I am happy to say that NPAF is actually launching just recently a new campaign called Hello. And so this campaign uses a game called Hello, made by this company called Common Practice. And it's just a conversation tool, a friendly, safe game that helps people have conversations about living and quality of life. So it helps people learn what words to use to really get the care that they need, and asks kind of deep questions about your values and your preferences and how you would want to be treated. One question that I love is it asks, tell me 3 non-medical facts about you. And so, as in a doctor's office, you wouldn't expect to be telling your doctor that, but it helps you kind of think about those things so that when you are, God forbid, in a doctor's office, hearing a serious illness diagnosis, you know what to tell them about you and how you want to be treated as a person. So it is helpful for those conversations rooted in person-centered care. And I think the other piece of this is, access to the actual offices themselves. So I'll just tell you a quick story about my own family. So my father, he's a 2-time cancer survivor. He's a trooper, and just recently has been placed on a feeding tube. And so that's a huge change in his quality of life. And mind you, when he was placed on this feeding tube, all he cared about was the cost. And he didn't really know how to say the things that were bothering him about it, that this is a huge change. And so we were inquiring about palliative care offices in the area, and this is in New York, and we could not find a single office that would take him because he doesn't have a cancer diagnosis, or he didn't have a serious illness diagnosis at that time, but yet would have benefited tremendously from palliative care. So I think, I know there are reimbursement challenges as well for palliative care and payment challenges as well. So I think there's kind of a 2-step approach of, those need to be addressed for sure, but then I think just spreading awareness that this is a beneficial service that can really address the whole person and put people at the heart of healthcare, I think that can't be understated.
Great. Well, thank you so much, Nicole, for joining us today. Really appreciate it.
Absolutely. Thanks so much for having me.
That's all for today. Stay tuned for tomorrow's AJMC On Location, where we will sit down with Dr. James Hamrick of Flatiron Health to discuss technology and care delivery, and Dr. Ali McBride to discuss biosimilars and more. Thank you for watching AJMC News Network. I'm Jamie Rosenberg.